Alterations in elimination. Renal. Disorders of the kidneys and ureters. Pyelonephritis is an acute or chronic bacterial infection of the kidney. It comes from common bacteria, especially E. coli. It can also be caused by obstruction. We see inflammation and swelling occurring with a resulting development of scarring and fibrosis that can eventually cause renal failure. These clients with acute pyelonephritis will have moderate to severe symptoms that resolve in 1 to 2 weeks. Chronic pyelonephritis will result when the treatment of the acute pyelonephritis is unsuccessful and the infection recurs. These clients experience flank pain, chills, fever, malaise, polyuria, nocturia, and hematuria. We diagnose with urinalysis, lab tests, CT scan, cystoscopy, and IVP. We're going to treat with antimicrobials and analgesics, do a follow-up urine culture, and prevent any progressive kidney damage, and potentially in the chronic situation and renal failure, we may need to do a nephrectomy, which is the surgical removal of a kidney. Nurses need to obtain that clean catch urine specimen and encourage fluid intake in addition to obtaining I's and O's. So true or false? Pyelonephritis is a disorder that can occur acutely or chronically. And that is true. Acute glomerulonephritis is an inflammation of the glomeruli in the kidneys. These are the capillaries that filter substances from the plasma. Primary would be an acute post-infectious process, and secondary results from other conditions and has a risk of kidney failure in some clients. These clients may not have any early symptoms. They may have a sudden onset with pronounced symptoms such as fever, nausea, malaise, headache, generalized edema, periorbital edema, hematuria, foamy urine, and pain. As the condition progresses, these clients may be irritable, experience anemia, have convulsions, hypertension, congestive heart failure, and oliguria to anuria. It is twice as common in men as it is in women. We diagnose with lab findings and potentially a percutaneous renal biopsy. There is no specific treatment. We treat symptoms, and we do this with bed rest, sodium restriction, antimicrobials, vitamins, diuretics, and dialysis. Nurses encourage bed rest when hypertension and edema are involved. We educate clients on medication and diet and monitor their urinary output. So true or false? Acute glomerulonephritis is twice as common in males as in females. And this is true. Chronic glomerulonephritis is a slowly progressive disease that's characterized by the inflammation of the glomeruli with irreversible damage to the nephrons. It is an autoimmune connective tissue disorder that results in scar tissue bands, renal failure, and end-stage kidney disease. It's also associated with Goodpasture syndrome and lupus. These clients may experience anasarca, which is generalized edema, renal failure, symptoms like fatigue, headache, dizziness, hypertension, and dyspnea. We diagnose with lab and urine tests, chest x-rays, ECGs, and percutaneous kidney biopsy. We're going to treat it by controlling hypertension and correcting fluid and electrolyte imbalances, reducing edema through diuretic therapy, preventing congestive heart failure, and eliminating urinary tract infections. Polycystic renal disease is inherited as an autosomal dominant trait. In other words, it's passed on from a parent. It may be an infantile form, which is rare and can cause death or childhood renal failure, and an adult form that progresses to renal insufficiency, formation of multiple bilateral kidney cysts that increase the size of the kidney from the size of a fist to a football. And it can be fatal within 4 years of renal failure onset. These clients may experience hypertension, pain, colic, hematuria, and renal stones. There's no cure, but these clients may be on drug therapy, diet modifications. They may end up on dialysis or have a nephrectomy. Nurses monitor vital signs, intake and output, and monitor for bleeding or infection. Kidney and ureteral stones are precipitates of mineral salts that generally dissolve in urine. They may also be composed of uric acids, cysteine, magnesium ammonium phosphate. The majority of kidney stones are composed of calcium oxalate and or calcium phosphate. They can be smooth, jagged, or what we call a staghorn shape. And there's a great picture in your textbook to show that. So initially we may see urolithiasis, which are stones in the urinary tract, nephrolithiasis, which are stones in the kidneys, and ureterolithiasis, which are stones in the ureters. These clients have predisposing factors such as calciuria, dehydration, UTIs, obstructive disorders, metabolic disorders, osteoporosis. They have a diet that's high in protein, sodium, and or sugar. They may be immobile or have a family history. This can result in hydronephrosis or distension of the renal pelvis. These clients experience severe flank pain and ureteral colic, hypotension, urinary retention, and they vary with size, location, and the cause of the disease. We diagnose with a urinalysis, urine culture, radiography, IVP, and kidney ultrasonography. We're going to treat with vigorous hydration, drug therapy, ESWL, a laser lithotripsy, or maybe even stent placement. Surgically, we may place a nephrostomy tube, do a percutaneous nephrolithotomy, or an endoscopic procedure, a ureterolithotomy, pyelolithotomy, nephrolithotomy, pyeloplasty, or a nephrectomy. We also teach the clients to strain their urine when we're suspecting stones, and we provide postoperative and post-procedure care. A ureteral stricture is a narrowing of the lumen of the ureter. It is rare, but it's more common if there's a history of chronic ureteral stone formation, repetitive inflammation or infection, compressive congenital anomalies or conditions. These clients experience flank pain or abdominal discomfort during periods of high fluid intake. We diagnose with a voiding cystourethrogram or an ultrasonography. We're going to treat the stricture characteristics, or treat depending on the stricture characteristics. It may involve dilation or a ureteroplasty, where we remove a portion of the urethra and stitch those ends together. Nurses provide intake and output, post-procedure or post-operative care, in addition to prevention of complications. Kidney tumors are typically malignant. The cause is unknown, but it may be due to a chronic carcinogen exposure and tobacco use. These clients may have an advanced cancer before it's ever diagnosed, and symptoms from the metastasis site might be apparent before the actual tumor is diagnosed. They may experience painless hematuria, flank pain, or there might even be a palpable mass. We diagnose with physical examination, x-rays, IVP, cystoscopy with retrograde pyelogram, ultrasonography, MRI, CT, or renal angiography. Surgically, we're going to do a nephrectomy, a nephroureterectomy, radiation therapy, chemotherapy, or a palliative treatment for metastasis. Nurses provide emotional support and postoperative care. So true or false? Renal tumors are rarely cancerous. This is false. They're almost always cancerous. So kidney failure is the inability of the nephrons in the kidneys to maintain fluid, electrolyte, and acid-base balance, excrete nitrogen waste products, and perform regulatory functions. With an acute kidney injury, this is usually reversible, and it's caused from prerenal or non-urologic conditions, intrarenal, which would be conditions in the kidneys, and postrenal disorders, which are obstructive issues in the structures below the kidneys. Classifications for acute kidney injury are referred to as RIFLE criteria, which is risk of renal dysfunction, injury to the kidney, failure of kidney function, loss of kidney function, and end-stage kidney disease. There's different phases with AKI, or acute kidney injury, and it starts with the onset, which begins with a contributing event. And we see acute tubular necrosis, which is the death of the cells in the collecting tubules of the nephrons, and it will last from hours to days. The oliguric phase is where less urinary volume is produced, and it begins within 48 hours after the initial injury, and it can last 10 to 14 days. We see fluid volume excess, edema, hypertension, cardiac complications, azotemia, hyperkalemia, metabolic acidosis, and uremia. We also see the diuretic phase, which is where the nephrons begin to recover and diuresis begins. But even though we're getting rid of fluids, the BUN, creatinine, potassium, and phosphate levels will remain elevated, and it will last 7 to 14 days. And then finally, the recovery phase. This may take 3 months or up to a year or more for normal function or optimal function to return. With chronic kidney disease, we see the intrarenal conditions or complications of systemic diseases such as diabetes or lupus. There's extensive damage to the kidney, so the client is not adequately removing protein byproducts or electrolytes from the blood and not adequately maintaining that acid-base balance. There's 5 stages that encompass reduced renal reserve, renal insufficiency, and end-stage renal disease. With chronic kidney disease, we see an elevation of the BUN, serum creatinine, and uremia. Clients develop hyponatremia, hyperkalemia, hyperphosphatemia, hypermagnesemia, and hypocalcemia. They may also develop a uremic frost on the skin, metabolic acidosis, anemia, edema, and immunosufficiency. For both processes, these clients will have elevated blood pressure, weight gain, fluid retention, bleeding, vague symptoms, and pruritus. We diagnose through laboratory blood tests, urinalysis, IVP, percutaneous renal biopsy, x-rays, ultrasound, or renal angiography. We're going to begin with preventative measures in treatment. It may require hemodialysis or peritoneal dialysis in the end-stage renal disease until if or when a transplant is completed. In addition, we need to provide appropriate diet. So surgically, these clients may require transplantation or immunosuppressive drugs. Client education should be provided on the diet, medications, treatment regimens. Education on rejection symptoms would be provided following a transplant. So kidney transplantation. Donors for a transplant will be selected from compatible living donors who may or may not be relatives, or from organ donors that are brain dead and whose next of kin gave permission for harvesting of the organs. Any potential donor with a history of hypertension, malignant disease, or diabetes will be excluded from donation. To facilitate matching a recipient with a donor, a client will be placed on National Computerized Transplant Waiting List. During the transplant, the non-functioning kidneys will remain in place. For example, look at your picture. The client will be placed on anti-rejection medications at this time, or at the time of the transplant, and those drugs will continue long-term. If symptoms of rejection occur, the client will undergo a biopsy of the organ, and if rejection occurs, dialysis will probably resume. Dialysis is a process that cleans and filters the blood to remove nitrogenous waste products and help maintain the adequate fluid, electrolyte, and acid-base balances through diffusion and osmosis. Substances in the blood will move through a semi-permeable membrane to the dialysate. So it can be completed through hemodialysis or peritoneal dialysis. With hemodialysis, we have a machine that will remove and filter the client's blood through a dialyzer. The dialysis cycle will take 4 to 6 hours to complete and is done about 3 times a week. It uses a tunneled catheter, an arteriovenous fistula, which is a surgical anastomosis of the artery and vein, or an arteriovenous graft, which is a vascular access method. They do lab and body weights pre and post dialysis, and other forms of hemodialysis would include a continuous renal replacement therapy, which is a continuous dialysis. Nurses would help with methods to prepare for vascular access, monitor for the disequilibrium syndrome, inspect the skin over the fistula or the graft for signs of infection, and palpate for a thrill, which is kind of that vibration of the blood flow through that vascular access, or listen for a bruit, which is a loud sound that's caused by the turbulent blood flow. And if it's absent, the nurse will postpone further use and report those findings. The nurse notes the color of the skin and the nail beds and mobility of the fingers before and after dialysis. Wash the skin of the fistula or graft with soap and water or an antiseptic. And after dialysis is completed, will not administer any injections for at least 2 to 4 hours to allow time for metabolism and excretion of the heparin, which is administered during dialysis, to reach those safe levels. Before the client is discharged from hemodialysis, again, observe for any complications. The nurse would also avoid puncturing the same site that was used previously. With peritoneal dialysis, the client will use the peritoneum as the filter. These clients have had a catheter surgically implanted into the abdomen. The types of peritoneal dialysis include the continuous ambulatory peritoneal dialysis, This is where about 2,000 mLs of dialysate is instilled by gravity into the abdomen. That solution will dwell in the abdomen for about 4 to 10 hours. It will then be drained and new solution will be instilled. And that procedure will be done 3 to 5 times in a 24-hour period. A continuous cyclic peritoneal dialysis is a machine that's connected to the dialysis catheter, and it continues that solution exchange 3 to 5 times during the night. With peritoneal dialysis, that drainage should be clear, but it may have a yellow color to it, but it shouldn't have a cloudy appearance to it. Nurses should instruct on the procedure of installation and drainage, and this is a sterile procedure to help reduce any potential infection, and teach the clients to report cloudy or bloody drainage.